All right, I'm going to go ahead and get started. And I'm going to get started first by thanking everybody for taking the time out to join us. A bit of what we were hoping to be able to do today is to lead this off with talking about how we had overturned the OTP moratorium. For those of you who don't know, that's the opioid treatment moratorium that would have allowed for more of our medically assisted treatment providers in the state to offer methadone as a treatment option. For those of you who don't know, right now there are 9 methadone licenses in the state of West Virginia. One provider has 7 of those 9, with another provider holding 2. What we think is that overturning the opioid treatment moratorium will again allow for more providers to offer more expanded services. That was actually one of the reasons that we wanted to have a conversation today, in particular about 340B. We believe that many of our HIV and hepatitis C providers take advantage or use 340B, but we think that MAT providers in the state should be also doing that. We think that, one of the things that the 340B provision does is that it actually allows for organizations that are providing direct service to be able to build on those direct services through a comprehensive reimbursement strategy. So we want to have a bit of a conversation about that today. So what I want to do is open up for a bit for Amanda and Lee to talk about where we are, what were the challenges, what were the, we do a bit of a SWOT analysis on what happened with overturning the opioid treatment moratorium. So what are the strengths, weaknesses, opportunities, and threats that we see coming forward? So Lee and Amanda, I'm going to give you the floor to talk about the OTP moratorium, and then we'll introduce our guests and we will go on from there.
Yeah, well, thanks everybody. Thanks to all our West Virginia statewide stakeholder members for being with us today. We have, I believe, reported even at WVSSC meetings in the last months about our work to expand methadone access in the state. And the short version of the story has had legislation introduced. It got pretty darn far, but it did not get over the final hurdle to be passed into law Saturday night. House Bill 4607 was the legislation introduced that we've been tracking, supporting, and educating on over the last 2 months in West Virginia. That legislation would have ended the OTP moratorium and allowed more providers to provide methadone in the state. The good news is that bill passed unanimously out of the House Health Committee with 2 lead Republican sponsors, including Delegate Rohrbach, the head of the House Health Committee. It also passed the House floor about a week later, back in February, on a vote of 61 to 38. That legislation then moved to the Senate, and we were able to get the Senate Health Committee to also pass that legislation. And again, it passed out of the Senate Health Committee unanimously, with both Democrats and Republicans supporting it. It passed what's called first reading in West Virginia on Thursday and passed second reading on Friday. And everything was teed up for the big vote on Saturday, the final day of legislative session, for it to be approved by the full Senate. We had every reason to think that bill would pass. I think at the end of the day, and we're still doing the SWOT analysis, but ultimately that bill got caught up in the politics of a state that has a requirement that your legislative session only lasts 60 days. And they have a hard stop at midnight on Saturday night that legislation has to have been approved by both chambers to have done so. Our bill was calendared along with more than 100 for that final day. And it was calendared right behind a critical race theory bill that the majority in the Senate clearly had an intention that was going to be timing-wise the very final bill, and I think had some political reasons that they wanted to have that be the last thing they did at approximately 11:55. So ironically, for those of y'all closely following West Virginia politics, that bill ultimately, because of some poor time management, was passed at about 12 o'clock and like 18 seconds. And if you followed the media narrative, ultimately did not go into effect in West Virginia, which I think in a way feels slightly ironic, but also a little bit gratifying that our bill was calendared right after that one, and kind of the timing of when they wanted that to pass ultimately meant that ours didn't pass. We did a lot of good work to advance this policy over the course of the year. There were 3 media pieces in the Beckley newspaper, and the Morgantown newspaper, and the Charleston newspaper, which was our original piece authored by Tony, calling out the need to reduce methadone stigma and increase access. You know, we've got a lot of bipartisan support from both Democrats and Republicans in both chambers. So I think this is not a question of if the state can overturn the moratorium, but when it is going to. We are planning at our April meeting to do a much deeper debrief with the West Virginia Statewide Stakeholder Coalition, including getting some key partner orgs and legislators to have a full kind of conversation about, you know, what happened in West Virginia over those 60 days related to HIV, hepatitis, and drug user health policy. So hope folks will plan to come back for that. Amanda, let me pass it to you to see if there's anything else we want to say before we dive into this combo.
I don't think that there's really anything else much to add. I mean, we are hopeful that we can possibly get the OTP moratorium up during the special session. There's already talk that Governor Justice is wanting to have a special session to appropriate some funding towards a maternity hospital in Ukraine, which would be about a $5 million spending package. So fingers crossed that maybe we can get that on the table for one of his special sessions within the next couple of months.
Perfect. Thank you, Amanda. Thank you, Lee. You know, I know, and so we have 3 very exciting guests today, this month. Dr. Jessica Ice from West Virginians for Affordable Healthcare. Are you here? Because I want to kind of start with you. Is she here? She make it? Nope. All right. Next then is Devon Lopez with Unite Us WV. And then you guys were doing a couple of policy pieces as well, right? Were you moving some stuff through the State House as well?
No, not at this point. I think we were in talks about some things, but nothing ultimately that we have really put through.
All right. And you guys are doing a bunch of stuff on Medicaid though, right? No. Am I get?
I was going to say, did someone else jump in before me? No. We're not. We were working with Aetna, and Debbie Hahn, I see, is on the call. And we're doing a lot of work with them under the Medicaid umbrella to get a lot of the people that they are supporting connected to services. We're still working with them, but just not in as large of a capacity. We are branching out all over the state.
So maybe instead of me telling you what you were doing, maybe you'll tell me what you were doing, and then we'll go to the folks at Avita about 340B. So why don't you tell us and tell me so we can learn about what you do so I don't sound like a fool again. All right. Devon? Hello? Did she freeze? I think she froze. She froze. Off to Avita we go.
Thank you very much, Tony. Hello. Thanks for inviting me. I am a pharmacist as well as the regional sales coordinator for Avita Specialty Pharmacy. So who we are the largest independent nationwide provider of 340B pharmacy services. So we partner with Ryan White organizations, FQHC organizations, STD organizations in the 340B program. And briefly, as Tony explained that, if you have a Ryan White grant or you are an FQHC or a STD clinic, and we partner with you, you may purchase medication at a greatly reduced price. You will receive the regular reimbursement from the third-party payer, and there would be a spread in the middle that would be a profit
Karla,
or a discount for you
Karla,
and your organization. Yes,
Karla, I want
me?
to ask you to back up, and I'm going to ask you to back up, and I'm going to ask you to slow down. Right? Okay. So first of all, is 340B a federal program? What kind of program is it? Where did it come from? What are you talking about with 340B?
Okay, yes, it's a federal program. I'm thinking back to the 90s. I don't know the exact date that it was passed. And basically it was passed to help the underserved, the communities, the AIDS Service Organization, the federally qualified healthcare organizations get more federal money to put back into their programs. So the program is designed to bring a revenue to the organization through purchasing these drugs at a discount price. The revenue comes back to the organization to use to increase programs, to increase reach, pretty much unrestricted, so long as it's going to benefit the patient.
Okay, so let me, and sorry, they didn't warn you. I interrupt a lot, but I do it so that we can make sure everybody understands
That's okay.
what we're talking about. So, so I have the Tony Young Clinic,
Mhm,
and I'm the Tony Young Clinic in Hardy County, West Virginia.
mhm,
I received some Ryan White money,
mhm,
and I received some other money.
mhm.
The rest of my money is none of your business. I got a lot. I got a lot buried in the ground in my backyard of my clinic.
Mhm.
But okay, no, let's say I don't have any Ryan White money.
Mhm.
I have no Ryan White money. I just have a bunch of money that somebody gave me through an endowment. Can I come to you and can I apply for 340B and get it?
The organizations that we can work with are federally qualified healthcare systems, FQHC, an FQHC lookalike, Ryan White grant recipients, TD grant recipients. There are other ones in particular with tuberculosis organizations, so some Native American
Oh, you're going in and out.
Indian reservation.
Yeah.
Grant. Okay. The same one are the FQHCs, the lookalikes, the STD grant recipients, and the Ryan White organizations. They qualify to be a part of this program. What they would need to do to be a part of this program is they need to work with a contract pharmacy. You can't have your folks show up, you write the prescription, and they go to the Walgreens to fill the prescription. If you decide that this is something that you would like to participate in, you need to have contract pharmacies that are registered on the HRSA website. So,
okay, so but what if I'm an MAT provider? I'm just a medically assisted treatment provider, but I use buprenorphine, Suboxone, but I don't. I think that I'm getting medical reimbursements for this stuff, but I'm not an FQHC. Do I have to get Ryan White waiver of some sort? Can I get is there a waiver I can get?
there's different ways to qualify. Probably the best way to qualify would be to become an STD clinic, because oftentimes we're going to find that the buprenorphine and some of your medications that you're using have a high rate of hepatitis and other STDs. And one of I think the easiest way to become an STD clinic is to contact the health department and take advantage of their 318 funding, which is their condoms, things of that nature, and go that route. But as you are right now, you don't have any of the STD, FQHC. No, you need to pursue one of those routes to play in the 340B arena.
Okay, now, all right, now I did it. I got a Ryan White grant. Somebody gave me a Ryan White grant, and I'm an MAT provider, and I'm a Ryan White grantee. Now what happens? Can I call you now?
You can call me now. It's regulated by the government, so we want to make sure that you're just not taking a patient that walks in so you can get that 340B money and then they run away. A patient qualifies if you have a record of that patient. They're even if you're not a physician, even if you're doing case management and referring that patient to a physician for the treatment, you have to have some type of record. And even, I have some organizations that I work with that are still doing paper record. So, Mr. Jones comes in this time, and we give him an STD test, and he has hepatitis, and he's also, doing a buprenorphine, blah, blah. So you have to have a record. You can't just start this clinic and start writing prescriptions left and right. So a patient has to qualify in that regard. But other than that, if you have the grant, you have a qualified patient, that would be when you reach out to a contract pharmacy, and Avita is one of many. And different contract pharmacies have different service fees. So you have to be prudent and shop around. You don't just want to sign up anybody. But once all your ducks are in a row and you have your grant and you have a qualified patient and you have your pharmacy, that is when you may start receiving that revenue. For example, the HIV medication is just extremely expensive. So I'll just give you an example. An HIV medication may be $1,000 to purchase. Your purchase price, because you are an STD clinic or a Ryan White clinic, may be $500. So that $500 in between would be the revenue you make on one prescription one time. So it is an extremely beneficial, lucrative program for your organization and ultimately for your patients. So all of that money is going right back in to programs.
So I want to understand. So at the Tony Clinic, we have a Ryan White program. We have now a contract pharmacy, which is you, because we want the best, so we went with you. And now we have a patient, we have a client. All right, so that client now needs a prescription for HIV medication. I get that, and so my trustee case manager, Amanda, has now written this person's prescription. Oh no, she hasn't written this prescription because she's just case manager. She's given them a referral to a physician. Does that physician have to be with us, or are you saying that physician could be any place?
The physician can be anywhere. The important factor there is to make sure there is a document in place, which we can provide. It's called a memorandum of care. That's going to link you with that doctor. So when that doctor e-scripts that prescription in, we have his NPI number, and we know that Dr. Jones is with the Tony Clinic, and that's who's going to receive the 340B revenue, unless you have your doctors on site.
Okay, so is it now? So I want to make sure I understand and everybody understands. So I know, Cordelia, I was getting ready to call on you. I swear it was on my brain to call on you. You don't even have to put your hand up because I'm going to call on you anyway. So is it that I need to have the doctor, or I need to have the patient connected with me? Because is the reimbursement then going to come back to the doctor, or is the reimbursement coming back to Tony's clinic?
The reimbursement is coming back to Tony's clinic. So when you contract with me, you're going to say, I have a memorandum of care with Dr. A, B, C, and D, and you're going to provide me with that information. And you're also going to provide me with a list of your patients. So when Dr. A phones in that, or e-scribes, usually how they do it, to Avita Pharmacy, we are going to fill that prescription, see the connection, home deliver that prescription within a 24-hour period, and put that revenue into the Tony Clinic. So once a month, we have a reconciliation where you will receive a statement. It will say every single patient that you had, the cost of every medication, and what that spread was, because you bought it really, really cheap. So, and then once a month, you will receive a check from Avita Pharmacy for those patients that you are sending.
Okay, we have a couple of questions.
Sure.
Cordelia, did I pronounce that right?
Cordella, thank you.
Cordella.
Okay, my question is,
Who are you and where are you from before you start asking 500 questions?
I am the HIV program coordinator, and I am in Southeast Texas. My question is,
Yes.
is there any oversight that ensures that facilities that receive 340B revenue put that money back into caring for the individuals who access the services, such as expanding services that would probably provide for labs and other medical benefits that are not covered under insurance or through their general funding, et cetera, et cetera?
There are audits by HRSA. I'm not auditing. I'm not coming to see what you've done. I'm hoping that you're all ethical, but HRSA, the government, the federal government will audit periodically to make sure that that money is being put to use for patient programs. With that being said, I mean, keep in mind, you have 2 case managers managing 100 patients. It could be hiring a new case manager. It could be, it's not, so that is helping the patient, right? If you're hiring new people, if you're expanding services, if you're buying a vehicle to service patients that can't get to the clinic. So it's unrestricted in that they're not, yeah, you can't put a built-in pool in your backyard, but anything that is going to help that patient, whether it's hiring new folks, new equipment, paying the gas and electric bills to keep your facility open, is going to count. And when you're audited, you're keeping that record. This is what we've done with our money, right? If you're audited.
Thank you.
You're welcome.
And so can you tell us now that my clinic is, man, we're flush because we've got 750 million clients and they're all now getting, I'm getting reimbursed for them all. Is there a cap? Is there a maximum amount of money that I can get on my 340B reimbursement?
There is not. And actually, if you've got that many patients, Avita's next step would be, let's put a pharmacy on site. You know how you get a turnkey home? We can put a turnkey pharmacy on site where basically we come in, shelves, select everything, and you've got a pharmacy there with that many patients. So we try to build your program to get you to that point where you can have that on-site pharmacy, because that's really the best way to care for your folks, is to have that pharmacist right there.
Now, there's some places that are trying to eliminate 340B. Can you say anything about that?
Yes, well, the pharmaceutical companies are angry about 340B at some points in time, because ultimately you guys are getting a great discount on their drugs. So they're not getting their $1,000, you know, reimbursement. They're only getting, you're buying them for $500. So a lot of the pharmaceutical, not a lot, some of the pharmaceutical companies have tried to limit the amount of contract pharmacies that an organization can work with, because you can work with as many contract pharmacies as you want, because patients like different pharmacies, right? Some patients want to go to the CVS, the Walmart, some might want to use Avita. So you can have 3 or 4 contract pharmacies to make sure you get all of that outreach money, because if a patient goes somewhere where you don't have a contract, you do not receive that 340B money. So what these pharmaceutical companies are trying to do is limit the amount of pharmacies that you can work with to 1, which what is going on is that's limiting patient choice. A patient should never be told where they need to go. So far, it hasn't been pushed through. I know we at Avita are adamantly, you know, vocal with the federal government in trying to, you know, stop this. And at this point, it hasn't happened. And we're hopeful that if we all keep lobbying, that it won't happen, because it's taking away patient choice.
Right. Like, I'm going to pivot in a second. Does anybody have any immediate questions about 340B? How many people on the call have right now 340B? I don't see anybody. Elisa Clements, I see you giving a thumbs up. You guys have 340B. Is that for all of the family planning clinics in West Virginia, or just one or two, or everybody?
It's just for our one Planned Parenthood in Vienna. We were able to get 340B when we were taken out of Title X. So that's how we were able to provide when we were taken out of the Title X program.
Okay.
Elisa, do you have, I don't believe you do 340B though. You qualify, but I don't think you have, you participate in the program, do you? Or maybe I'm mistaken.
Well, I'm not sure because I don't run our health center. I do our lobbying efforts. And our health center manager and our CFO would know better about that, but because our CFO handles all of that. But I do know I met with folks at DHHR and we were talking about different ways that we can still provide STI and HIV testing and treatment during the Trump administration when we were taken out of Title X. So I was like, I know about 340B because I've seen many emails about it, and I've met with our CFO and I met with folks from DHHR about it. So I'm not sure where we stand now because that was a couple of years ago.
Okay, got it. All right. So thanks. So if you can stand by for me, Karla, I'm gonna go to Ms. Lopez now, and she's gonna tell us what she does because I clearly had it all wrong. But now she's gonna tell us actually what she does, and I won't get it all wrong again.
Thanks, Tony. And sorry, my internet, I'm in Charleston, but my internet sometimes is unstable, so it'll kick me out like that. I apologize. But yeah, so I work for Unite Us, and we power our Unite West Virginia network. And basically what it is a technology platform that allows, I call it the 3 C's, for communication, collaboration, and coordination for an individual's care beyond their 4 walls. So it is a platform where you can send out referrals for services for people that you're working with, for services beyond your 4 walls. So, you know, a lot of those traditional referral models may look like a pamphlet in the office or a case manager or social worker calling to try to find a good connection for someone to receive, let's say, housing support or food. With our platform, it's completely free for nonprofits, community-based organizations, most FQHCs to join. It's a web-based platform, so it's nothing that needs to be downloaded on your computer. And once you have access, you can actually see a list of who are the organizations currently on the platform, what services that they provide. We try to provide a spectrum to everything from any type of health service you could think of to wellness or spiritual enrichment programs. I mean, if I needed to find a community volleyball league, I could use the platform to refer to those services. And on the other end of the spectrum, if I was in need of emergency food assistance, I could be referred to on the platform for services. But the way the referral platform actually works is after an individual reports that they have a need, the entity or individual at the organization that they have expressed the need for would log into the platform, generate a referral for that individual for, let's say, food assistance. When they click food assistance, the network is going to auto-populate to all of the providers first within a 50-mile radius of either the address of the individual or of the organization generating the referral. But they can remove that filter at any time. And from there, the person will select one or multiple organizations to receive that food assistance referral. Once they click send on that food assistance referral, the food assistance providers will actually then get a notification that someone in their community has this food assistance need. They will in turn log into the platform, look at the referral in its totality and determine whether or not they can work with the individual. If they can, they will take action and accept the referral, and it will send an automatic notification back to the organization that created the referral that this referral for food assistance has been sent out. It has been accepted and there is intervention happening and services being provided. Moving forward, they can use the platform as a case management tool if they want to document interactions or notes or services rendered. And once they have received that food assistance, they would close out that case and report on it as resolved or unresolved, but specifically how or why. And aside from that referral platform itself, there's a whole data collection platform that we have. So the data belongs to the organizations themselves. They can export the scope of work that they're doing at any time, how many referrals they're sending out or accepting, use that for what may be grant writing or grant reporting, whatever they might need it for. But there's also some higher level dashboards that are tracking things like co-occurring needs. What are the demographics in certain regions of people that are in need of help? Ultimately identifying where service gaps in our communities may lie, and where not only organizations and communities can kind of come together and advocate for more resources, but more importantly, where higher level organizations and our company as well can reinvest back into the community.
Is it okay if I call you Devon?
Yeah, absolutely.
Thanks. Hey, so, and I know I'm putting you on the spot right now, and I don't even know if it's going to work, what I'm getting ready to ask you to do, but can you screen share like this and then maybe show us this dashboard? Because this is sounding like some good stuff, and I want to make sure that people can see it. I don't know who's in charge of this whole Zoom room thing, but can you give Devon some screen share possibilities?
She's good to go.
Awesome.
Okay.
All right. Let me just pull it up real quick and make sure I have my demo network, which I have all the time.
So, I mean, so this is like case management software online. Is that what I'm understanding, or no?
It can be, yes. It can be, absolutely. So, sorry, I'm just trying to find my demo accounts.
I know, I did this to you. I mean,
Oh no, that's what I'm happy you did. I'm happy to provide it.
And is this just for West Virginia, or can anybody use it?
So actually we have our West Virginia network, but we've most recently merged into a larger network called Unite SD. So you can even refer over state lines. So any organization or community service that might be needed. And that was something that was really important in places like the Eastern Panhandle, where we're, growing this network. A lot of times they'll hop right over into Virginia and need to receive services. So, we've made sure that all of our surrounding states have access to be referred out to as well for a lot of people that will go into those states to receive those services.
Okay, perfect. Thanks.
Sorry about that.
This is a way to bring folks together and kind of manage the handoffs of patients or clients who have multiple needs and still provide that touch with them.
So Doug, you use this, Doug, or?
Well, I've been pushing it and championing it for the past year.
Uh-huh.
And I'm sure Devon will tell you who's got the mostest of the mostest in West Virginia. But I have friends at Kaiser Permanente. Kaiser Permanente has endorsed this in California. And also we had a demonstration from George Mason University Health Science Center, the nursing research department that's actually teamed up with Kaiser Permanente and several organizations in Northern Virginia to include federally qualified healthcare centers to do a better job. And I say do a better, more easier, faster, and with better human touch, because you're taking some of this Rolodex, on the back of a notepad referral system and totally automating it across the platform. Now, when I say automate, it's literally an app that sits on top of systems. Yes, you can pay for additional capability, but for the most part, anybody who is a social service organization, they can sign up for free, and then they start building their network and they use it. So I've been listening to the community education group mission. This is a great opportunity, and I think it fits in with who you are, what you do, and then also bodes well with your grant and your vision. So, Devon.
Thanks, Doug. I swear, Doug does my job better than I do sometimes. So I'm like, should they hire Doug and not me? But no, I really appreciate Doug.
I
Did I
appreciate
sound
it.
as, did I sound as charismatic as Tony? Hope not.
Well, thank you, Doug.
Or-
So let's take a look at this. And can you give us let's take this pony through its paces.
Awesome. I'm going to stop my video just so can everyone see my screen okay here?
Yep.
Okay, so this is what it would look like to log into the platform from the provider facing. So it's really easy to log in. Once you're signed up to use the platform, you just go to westvirginia.unitus.com. There's a place that says for partners and a login, and it brings you right to here. So this is actually our demo environment. So when you're looking at this information, just understand that it's all dummy information so you can follow along. But once you log into the platform, what you're going to be first brought to is kind of your organizational dashboard. So you'll see in the top left-hand corner here, today I'm impersonating Rural Health of West Virginia on a demo environment. And in the top right-hand corner, I'm an employee of Rural Health of West Virginia. My name is Jeff Graham. Below that, you're going to see a couple different things. On this initial dashboard, that's going to show your activity, what is happening within your organization on the platform. If you have any new referrals, they're going to show up in incoming. There's an option to hold a referral and review. So if you receive a referral and determine maybe it doesn't tell you everything you need to know, you can mark it in review. It's going to let the sending organization know, I see and acknowledge that referral. We're just not sure if we can help them yet. Once a referral is accepted as an organization, it then becomes an open case. Hence why I said you can use it as that case management tool. So that's the point of the open cases you'll see here. And as you all might have heard me recall earlier, after these service episodes are met or unmet, an unresolved service episode in our platform is not bad, but it's giving us that, important information to know how or why these service episodes are unresolved. But we're always making sure to close out those cases and report on how or why they were resolved or unresolved. And then below that, you're going to see an organizational timeline, something really similar that you'd see on LinkedIn, on Facebook. It's going to be that chronological overview of what is going on at my organization. If we're sending referrals out, if we had an interaction with an individual, what was the outcome of that? If there's notes added, things like that. So this is going to be the first dashboard you'll see. And then at the top left-hand corner, you'll see dashboard, clients, reports, and my network. Dashboard is going to be where the referral activity will live. So you'll see if I click into it, looks really similar to an email inbox. This is where we can look at all of the activity within our organization. So if I click into open cases, we don't have any right now, but if I go into closed, I'll see that we have a closed case for Stacy for physical health services. She received information, so we know it was positively resolved.
Hey, Devon, I have a question for you.
Sure.
How hard is it for an organization to upload all of to input all of their information, all of their data into this?
So when we think about that from a larger scope, that's really when I would pull in my higher level team to help with that. I don't know in a lot of instances where an organization has actually uploaded past data. They're using this kind of just as a tool moving forward as the need arises. So if I was maybe working with a client who has been coming to my organization for a couple years to get services, and they've all of a sudden identified that they have a need that can be met via a referral in the platform, that's when we would advise that they would go in and create that referral, create that profile for them. Now, actually creating that profile, or what we at Unitus call a client face sheet, maybe takes 5 minutes to create, and it happens when you start that referral process for them. So I'm happy to walk you through that real quickly too.
Okay.
Awesome.
Yeah.
So if we have an individual that's coming in, like I said, has maybe a food assistance need, we're going to go click this plus button at the top and click new referral. We'll first ask for first name, last name, and date of birth. And we do this so we're not duplicating client records within the platform. We want all of their services, whatever that may be, to live under that same face sheet for them. So we'll go ahead and put that information in. And
is this all HIPAA compliant? What's the security?
Yeah, we're HIPAA compliant, FERPA compliant. We align with the strictest federal compliances, and within services that we call sensitive. So, mental behavioral health, substance use, legal assistance, physical health, within those organizations that do provide those services, there's some extra parameters we take to protecting that client information. For example, if I'm a food assistance provider working with someone who may have received mental and behavioral health previously in the platform, because I was not directly involved within that referral or interaction with them, I would actually not be able to see they received those services through the platform.
Okay. But but if I put in their name and I put in their birth date, would it flag me that they had received a service somewhere else, but it just wouldn't tell me what? Because what if
So-
they're getting a similar service that can't now be can't be reimbursed or should?
Yeah, so it would show within their face sheet their activity. So if they had multiple cases open for services at a certain, so if I had 2 food assistance requests via a referral, there's ways to avoid that duplication so that only one organization will pick up that service. In the event that they would be receiving maybe multiple types of the same service or different types of services at the same time, that would actually live within their client profile, and it would show you a list of all of the open cases they currently have at that time.
Got it. Okay.
So like I said, we're just going to put that information in really quick and search our records. Again, because Wesley has not been referred into the platform before, we're going to need to capture some of that information. You'll notice if there's a red asterisk, it's required to be filled out. However, you will also notice if they choose not to disclose, they 100% do not have to disclose. Now, obviously, the more information we have, the better able we are to service them, but making sure that they feel comfortable being referred to on the platform is one of the most important parts of using Unite Us. So we want to make sure that they feel supported. So we'll get that information in there if we can, that contact info, if they have it. Get that phone number put in. And then we can even indicate how they'd like to be contacted, when, how, best time. And then we'll put an address type, and understanding that not everyone feels comfortable providing an address, or maybe not even may not have a permanent address. So in this instance, what we do suggest is that you put in at least the city, state, and zip code, and I'll show you why on that next page. So let's just go ahead and say we are. And I'll click Save Client. So that will then, that has then built that profile for them. So that's as long as it takes to build a client profile, just by doing that information. The next step will actually be generating that referral for services to them. So if I go to this drop down right here, you're going to see phrases in black and phrases in blue. What you'll see in black are what we call our service parent types, but we understand those are really vague. Like, what is food assistance? All food assistance isn't the same. So you'll see if I type in food assistance, we've got some subtypes that are going to populate down, so that when I click on emergency food, the network's going to populate to organizations that have indicated when they signed up for the platform that they provide emergency food assistance. So it's not going to show me all of the food assistance providers. It will only show me those emergency food assistance providers. And in determining who to send that referral to, I can do so in a couple different ways. There's a drop down. It'll show you where they are from location to that address we just put in on that previous page. But my favorite function is our browse map. It's actually going to show me where these organizations are located on a map. And more importantly, I can click into those organizations on here and I can see who they are, what type of different programs they provide, if there's any eligibility requirements, what type of food assistance they provide, if there's any geographical boundaries or populations they might be catered to. So really understanding before that referral is sent out that this individual is able to receive their services. And if I determine it's a good match, I'll click plus, add recipient. I can add, so right here, Tony, is where we talked about, you know, how do I know, or how am I avoiding duplication? So you'll see there's the option to send a referral to multiple food assistance providers here. So if I click add another recipient, a box should have popped up. It might just be in slow today that would say, all right, here it is. Automatically recall outstanding referrals after the first is accepted. By having this box clicked right here, it's going to tell the referral to act like Lyft or Uber, right? So what will happen is this referral will go out to both Coalition of Food and Farmers and Demo 211. The first organization to see and accept that referral will get to work with the individual, and it would automatically fall off the queue for the existing organizations that hadn't yet responded. So that's one way we try to avoid that duplication, but we also understand sometimes there's collaboration meant to provide services. And we see that often with financial assistance. So in that event, you wouldn't click that plus button.
All right. So listen, I think this is great stuff.
Yep.
I know Doug's using it. How many other people that are on are using it? Let's see. Let me see if I can see. Do we have any more people using it right now? And if people wanted to sign up for this, what do they need to do? Amy
Yep.
Snodgrass is using it, and Amy Snodgrass has my favorite name. So
Right.
if she's using it, it's the best thing. Amy, tell us about it real quick because I
Sure.
still got to get to Jessica.
Yeah,
Jessica,
definitely. Really fast. Yeah, we're looking, we are actually currently writing an RCOR grant to address social determinants of health. And we have Partners in Health on the line right now too, on the call, Hillary Payne. And yeah, I mean, we looked at this and think it's a fantastic way to connect patients within clinics for sure.
Okay, so you're going to use it with all of the existing clinics that are internal to WVU or
Yeah,
external?
within our core service area. So we're really looking to get at, people connected to Unite Us and Devon to get them on board.
All right, so Devon, and we've got some people on here from as far away as Texas.
Sure.
Is this something that they could
Yep.
use or adapt in Texas?
Yep, we've got networks in over 45 states, and our goal by the end of the year is to have access to a platform in every community, county within the entire country. So there's actually a quite big Texas network too.
Okay. Kadia, have you ever heard of this thing?
No, I haven't heard of it. And in fact, I'm working with a group to put something like this together, but we never thought of a dashboard. So this is very interesting. And I'd like to connect with Amy to see how we can become a part of it.
You mean Devon? Amy is using Devon stuff, but you want to talk to Devon.
Devon, yes.
And Devon's the hookup.
Okay.
Devon's the hookup. Amy's just the go-between.
All right. I'm putting
Right.
my email address in the chat.
Great,
Okay.
I'll reach out to you.
Thank you.
All right, and then Devon just put her email address in the chat as well. So folks down there, Stephanie Lancaster, you had your hand up about, don't cause any confusion, Stephanie Lancaster.
I will not, I promise. I just want to make sure I understand because it sounds to me like this is the tool we have been all needing to make a single point of connection for anyone who needs any kind of social service so that we don't have to enter them multiple times or do a separate food stamps versus mental health appointments versus addiction and recovery versus transportation. It's a one-stop single sign-in.
Yep, single sign-in, no wrong door approach. That's exactly what we're doing.
Right.
And so this reminds me, Tony, of all the millions of people who've tried to create apps for Who Has Narcan to connect people, in a networky way with an app on your phone. So I guess my point is, and Tony, I hope you'll appreciate this. Let's all just use this one and stop creating new ones.
And it's free. So yeah, it's free. So in order to sign up, you have my email address there. But if you go to westvirginia.unitus.com, there you can access the sign up there. It's an online form. Depending on the size of the organization, takes just a couple minutes to fill out, or we can schedule a one-on-one workflow meeting and help you determine how you want to use it. And then from there, it takes within about 24 to 48 hours to get built into the platform and licensed to use it.
And
So
how
we
do
have
we
a question.
How do we pressure the 5 states that aren't already involved to get involved so that we can stop recreating the wheel?
Yeah, we're already actually standing them up. So if in the event that we don't have a funder in those states, we're operating ahead of revenue. So we're building these platforms before we bring our revenue streams on. And I see Allison asked, how we're funded. Different ways. In Virginia, there's a state in North Carolina, it's called NC Cares 360. It's funded through the state DHHS, DHHR, health systems, hospital systems that we provide full scale integrations with that actually integrate with their electronic health record systems. So it looks a little bit different for every network. And yeah, Debbie made a great point. For the doctor that refers a patient for services, they get that feedback immediately that the patient got those services. So the funding looks different everywhere you go in every state, every network. So a lot of our funders actually fund multiple states. So I always say because we're providing this service, we are a for-profit company, but we operate under that nonprofit lens. So, my goal is because I believe and I chose to stay in West Virginia. That's why I'm so invested in this work.
All right, well, we appreciate it. Thank you so much.
Thanks.
And I now I want to go to Dr. Ice, who has joined us. And I know that Dr. Ice has had a few bills that were going through the House and the House. And can you give us an update on what happened to you yesterday over the weekend?
Well, it feels kind of bad, I'm going to be honest. Thank you for having me here, but it's not all bad. So I was asked to speak to two things that we have been working on specifically. So I'm with West Virginians for Affordable Healthcare. I'm the executive director. And generally, we view ourselves as a education kind of organization, but during the legislative session in West Virginia, we do use our ability to get active there because we think there's a lot of things that we can make an impact on for West Virginians. So, you know, one of the things we worked on for a couple years, and I'm just going to give two quick overviews of these things and then welcome questions. So, you know, one of the things that we worked on was we call it a Medicaid buy-in. We framed it as a work bill, but essentially what it is West Virginia did really well when the Affordable Care Act was passed. So Obamacare was passed. We did super well. We went ahead and expanded Medicaid for our state for folks that earned up to 138% of the poverty level. So like working folks, but you know, poor working folks, right? We did that, and then we started seeing this thing where after the ACA, you know, even after you reach that 138% of the federal poverty level, you end up making too much money to qualify for Medicaid, but maybe your employer doesn't offer company-based insurance, or your plan on the marketplace is too much. We thought we call this the Medicaid cliff, right? So you fall off. It's not a gradual thing. You just, nope, after you earn so much, you're done. And this is a big problem for low-income working folks and families. So we thought, what if we could expand that and work with DHHR and others to expand that limit, and then, you know, have premiums and copays and those sorts of things that can add up until you're at what we proposed was 400% of the federal poverty level. You know, for a single person, the federal poverty level is just under $13,000 a year, right? So this gives folks, you know, they can accept that promotion, they can work more hours, and they can still have their health care. This was the second year it was introduced. We got it introduced last year, but it did not make any traction. This year, we've got folks, bipartisan, both sides, Republicans and Democrats, interested in it. Now, I'm going to say it's a big bill, so we're not surprised that it didn't pass this year. But this is something we're going to keep pushing, because having like some more affordable health insurance, if we're living underneath of, you know, this system where you have to have insurance to get health care, it has to be affordable for folks, right? Access, affordability, equity, all of these things matter in healthcare. So that's a lot of what this one is, and I'll answer any questions about that. But this is a fight for another year, I'll say.
Now, are you, I mean, so what are your next steps? I mean, are you just gonna wait it out and wait till next session? What do you do in the meantime? What's the plan?
In the meantime, we're actually working with a lot of organizations. I've presented it to different organizations, everyone from, you know, the physicians associations to social workers to the alpha deltas, right? So like all of the, like everywhere I can get this out, and we will have steps, we will have ways people can participate in it. I'm sorry, I've got like a cold, so I sound like a
No, you sound like somebody who's been yelling or talking to people in the House and the Senate for the last year. That's what you sound like. You sound like Amanda and Lee sounded about a week ago.
Just always just, yeah. But yeah, no, we've got lots of partners. We've got partners across different communities that are interested in this. So it's not just West Virginians, it's the homeless population, it's the communities of color population, it's the disability population. Like it stretches across everybody, right? Any families, right? It's a family bill. So we're not going to let up on this. We will push it for the entire next year because we think this is something that would help all West Virginians, those working West Virginians that, oh, Doug sent a message, but I'll read that in a second, Doug.
Don't let Doug cause confusion here.
Yeah, he's confusing me.
Don't let Doug cause confusion.
Yeah, no, so, you know, a lot of people would feel kind of sad about it not making it further, but I'm telling you, this is a big bill, and that we got so much support for this gives me a lot of hope for the next year. So like I said, we're like an education type of thing. So our plan is to educate the public and legislators about why we can do this, how it would help, and how we can do it, because we've already figured out the how we pay for it part. Like, we've got this. So we're gonna keep pushing this one for the next year.
And so what I want to say is that I think that you are one of the examples that we like to follow and that we like to shine on. And in this way is that so many people think that they can't educate legislators. They can't educate them on what their issues are. More importantly, what the issues are for the people of West Virginia. And I think that some people say, well, that's lobbying. And I'm like, no, if a legislator doesn't know, they don't know. And if you know, you need to educate them on what you know and what they need to know. And this isn't about trying to sway them. It's about trying to give them more information so that they can make informed decisions. That's what we are hoping that we like you, we got invited to the dance, but we didn't get taken out to breakfast, if you know what I mean. And so everybody just shook their head at me. I think I took that analogy a little too far. But you got the point. So, we didn't get the OTP moratorium passed, but people told us in this state a year ago that we couldn't make it this far. So I think that, we've made it much further than anyone gave us credit for. We made it further with our partners. We made it further with community members like you. And I think that that's exactly what we do, is like, now you know that you can call on us when it's time to go back, and so that we can talk about what you want us to talk about. And when we're in the room, you're in the room. And I think that that's one of the things that we have to do more of. When you're in the room, we're in the room. Your issue is our issue. My issue is your issue. And I think that what we want is the same thing. We want a healthier, happier, better educated, more employed, better insured West Virginia. And that's what we're all, I think, all after the same thing in a very similar way. And so I want to thank, I know we're out of time, so I want to thank Karla for giving us the education on what is 340B. If you're a Ryan White recipient, I think that is something that you certainly should consider. If you're an FQHC or FQHC lookalike, I certainly think it's something that you should consider. And I want to thank Devon for talking to us and showing us this new dashboard. I don't know if it's new, because it sounds like Doug's been using it and not telling anybody. But now that we all know about it, we can use it too. But like I say, Doug likes to keep stuff to himself sometimes and then come out with a big surprise like, hey, look at me. But now we all know, and we'll see Doug there using that. And I think that, Amanda, And Dr. Chaddock, I think that maybe it's one of those things that we could use for that new DHHR project, where even with the tracking some of the participants, the CHAMPS participants, might be a good thing. But as always, I want to thank you, because I like these, not just because I get to see some of the people I don't get to see a lot, but because I always learn something new. And I learned something new that's going on here in West Virginia, and we make some new friends. And again, if you need anything, if you heard something and you want some follow-up, don't call me, because I won't respond to your email, but you all know that now. You will probably go to Amanda, or go to Ashley, or go to Lee, and they'd be happy to get you a response on those questions. Or you could go to Doug Anderson, because he knows everything. But you should come to our monthly group and go to his monthly group, because we all share information. Again, have a great look. I think spring is sprung. I don't know about the rest of you, but that was way too much snow for me after having experienced the 70-degree day to then experience 6 inches of snow. It just felt a little disrespectful. It felt like disrespectful in a really big way, that I was just like, why do you need to do this? So now you're gonna make us do environmental work, because clearly there's something wrong in the system. So now you're sending us down that road. All right, everybody have an amazing week. Thank you. We look forward to seeing you next month, where we will be doing a deep dive into the OTP moratorium. And maybe Jessica, maybe you could come back next month and talk to us kind of about what the process is, right? Because that's what we want to really talk about. Process, again, about making sure that people understand that they can have their voices heard in the State House, and that there are opportunities for bipartisan support in the State House.
Absolutely. Contact me, Tony. I would love to do that. This is my cool thing I love to do. So
100%. Thank you. And thank you, Karla. Tell everybody back there at Avita I said, hey, and we need more socks. They have the best socks. They give away socks.
I will absolutely do that. And I did provide my email in case someone wanted to know a little bit more about 3. Be happy to discuss with anyone.
Can I get socks if I email you?
You can get socks. You can get pencils.
I need the socks.
Notepads.
Listen to me, people. I never say you wrong. Don't ask some people for a pencil. You better get them socks up off those people. All right.
Gotcha.
Take care. See y'all soon. Thank you very much.